Alrighty, part 2 of Pathophysiology is tonight. So this is going to wrap up patho, and then next week, I think Joe already told you guys, we're going to get into airway management. So you guys were here for it. Joe mentioned bring your skill sheets for your psychomotor exam. That's going to incorporate oxygen supplementation and delivery, airway management. Those are kind of the two big ones we're going to talk about next week and start gearing you towards your psychomotor exam. So tonight, wrapping up patho, tonight we're going to talk about the cell, specifically the human cell, regulation of homeostasis, the cardiopulmonary system and things that can go wrong with it, and shock. Joe already touched on patho of the other systems, so tonight I get to talk about the cool ones. So, introduction into patho. So pathophysiology is the study of how disease processes affect the function of the body. If any of you take a college course on pathophysiology, I took one. It's very cool just to learn about everything that can actually go wrong with the body. So it's an understanding to help you recognize changes to patients going forward, helping you recognize patterns towards certain illnesses, disease processes, that kind of stuff. So we're going to start with the cell, specifically eukaryotic cells. So a cell. The cell membrane is the beginning portion. I'm going to kind of flip back between this picture and this slide here. This picture just shows the general structure of a cell and all its components inside. You need to understand kind of each component, the more important stuff. So the stuff I highlight in this is the stuff you need to know. So the outer portion of the cell is the cell membrane. The cell membrane protects and selectively allows water and other substances in and out of the cell. So the cell membrane, which is kind of that orange-colored outside section of the cell, that's made up of phospholipids, which are basically fats and proteins, and those selectively allow water into and out of the cell, and it also allows certain electrolytes and different components into the cell. Oops. Another component, mitochondria. This is something you definitely need to know. What is mitochondria? So mitochondria helps to convert glucose and other nutrients into adenosine triphosphate, so ATP. ATP works to fuel cell functions. Without ATP, many of our cells' specialized structures can't function. When energy is needed by the cell, it is converted from storage molecules into ATP, and then ATP then serves as a shuttle, delivering that energy to places within the cell for energy consumption activities, whatever it needs the energy for. So ATP, chemically it's considered a nucleotide. So any of you guys studied about DNA structure and that kind of stuff, the main component of DNA is a nucleotide. So nucleotides are the building blocks for our DNA. There are 5 main components of a nucleotide, so whenever they're doing genetic coding or anything like that, this is what they're actually looking at, is the structure of the nucleotides and their sequencing. So the 5 main nucleotides that exist include adenine, cytosine, guanine, thymine, and uracil. Okay? So the way you would see that sequenced in a structure would be A for adenine, C for cytosine, thymine, guanine, and uracil. Okay? So these are basically the building blocks of our DNA. So all nucleotides contain a 5-carbon sugar backbone with a nitrogenous ending in a phosphate group. The phosphate group is what actually distinguishes the portions of the nucleotide, and phosphates are kind of the big thing when it comes to ATP and energy release. So ATP is converted into ADP. So ATP is adenosine triphosphate, ADP is adenosine diphosphate, so one extra phosphate group. And when it converts ATP into ADP, it's losing a phosphate group through a process called hydrolysis. So hydrolysis is when water is used to lyse or break away a certain phosphate group on the ATP to create energy. So if we're looking at our cell, this is a eukaryotic cell, so a multicellular organism. This is what humans have. So on the very outside, you see our cell membrane. We already talked about how that allows water in, water out, electrolytes in, electrolytes out. We also have our mitochondria. So the mitochondria, it's not very blown up, so you can't see it very well, but this is kind of the basic structure of mitochondria. So mitochondria work as the fuel refinery to convert glucose and other nutrients into ATP. So that's the mitochondria's main goal, is creating energy for our cells. So that is where cellular respiration occurs, and it also works in converting food into energy. So food gets broken down, certain molecules and nutrients from the food are able to pass into our cells, and then our mitochondria takes that in to convert it into energy. It's not just naturally energy for our cells, it actually has to be made into energy. That's what the mitochondria do. Also in our cells, we have rough endoplasmic reticulum and smooth endoplasmic reticulum. So rough ER, rough endoplasmic reticulum, there. So rough ER is involved with the production, quality control, and dispatch of proteins. So proteins are kind of our building blocks for our cells. They're in our cell wall. They're used for metabolism and different functions. And endoplasmic reticulum's job is to produce proteins, creating proteins, and then dispatching them to where they're needed. Smooth ER is involved with detoxification of products from natural metabolism, and it's typically found abundantly in the liver. So if you think about what our liver does, it detoxifies our blood. Liver cells have large amounts of smooth ER, and that's that smooth ER's main job, is to get rid of the waste products, break down fats and lipids, clean the blood basically. And the other portion that you need to know, so we have ribosomes. Ribosomes are those small little granules that you see in there. They're part of the rough ER, and the ribosome's main job is to translate the encoding from messenger RNA to combine certain amino acids and polypeptides for the production and release of cytoplasm. So it's basically the structuring and production of our DNA. It works as the messenger. Our nucleus, which is the center, kind of the brain of our cells, our nucleus is encased by the nuclear envelope, which basically separates the nucleus from the cytoplasm, other byproducts and chemicals within the cell that could damage the nucleus. So that's the nuclear envelope's main job, is to protect the nucleus. The nucleus, let's pull down here, regulates the function of cell growth and metabolism. It carries genes for our DNA coding, and it also produces energy for the cell, or regulates the production of energy for the cell. So our nucleus holds our genetic coding, and to figure out what form of cell structure needs to be developed, encoding different DNA, depending on what's needed for the cell. That's where the DNA is held, is within the nucleus. Any questions with that? I just gave you 3 months worth of biology in 20 minutes. That's the basic structure of a cell.
It doesn't go into much detail in here.
Yeah, our books are like lacking 95% of what you just said.
This is, so that is in general what a cell is. Your book doesn't talk very much about it because in EMT school, that kind of stuff, you don't need to really necessarily know all the portions of a cell. It's mainly what can go wrong with the cell.
Okay.
So that's why I'm talking about all this, is because we're going to go into how this stuff can go wrong. And that stuff you're going to need to know.
Like lysine-crenate. I butchered how to say lysine-crenate. Or I butchered how to say it. But you know, like where they lyse and then crenate.
Yep. So hydrolysis is a form of lysing, which is basically just the breakdown of a substance. Hydrolysis is breaking down with the use of water.
Yeah.
That kind of stuff. So, one main thing you need to know, water in the cell. Cells need the correct balance of water inside and outside. Too little water can cause the cells to what? Hydrate. What does that mean? What does that do to a cell?
Can't break down energy sugars, glucose.
It would. Yep. Have
Oh,
difficulty
it
with
could.
breaking down
Well,
glucose.
you could, but they would be inefficient, creating more waste.
Wouldn't it just kill the cell?
Over time, yep.
Yeah.
Because it's shrinking the cell. If it shrinks the cell, it's basically going to denature the proteins within the cell. Then it won't function appropriately. Your mitochondria won't be able to produce energy. Your ribosomes won't be able to encode and differentiate your mRNA to produce more DNA. So shrinking the cell does the cell no good, right? So it dehydrates and kills the cell. How about vice versa? If we have too much water, what does that do?
Expands it.
Expands it, yep. Because water is going where?
Into it.
Into the cell, and the shell's gonna...
It could burst.
It will, yep. Interestingly, if you ever get blood on your shirt, on your pants or something, you put water on it, does that take the stain out or make it worse?
Usually makes it worse.
Makes it worse. Because your cells are actually hydrolyzing, they're increasing in size, and it makes it more difficult to get the blood stains
That's
out.
why you
Hydrogen
use
peroxide.
Hydrogen peroxide, yep. What's
club
that?
soda.
Soda?
Club soda. It's out blood.
I never tried club soda.
Just use hydrogen peroxide though.
Yeah. I use OxyClean. Works really well.
Tide pens.
Anyway, so understanding that, because our cells, when water shifts from lower concentration solids to higher concentration, that's called what?
Osmosis.
Osmosis. Yep. In the sap industry, they use reverse osmosis, which is basically taking higher concentrations or lower concentrations of water out of the sap so it'll boil quicker and they can produce more sap more efficiently.
Was higher sugar content.
Higher sugar content, yep. The higher sugar content you can make, the quicker it is to make sap. You're not spending as much time.
And
There's
the better
too
it
much
is.
water in the
Right.
cell, I'm sure it's an actual problem, but like if the cell membrane lets water in and out, if there's too much, wouldn't it just get out where it doesn't need?
Depends on your solvent concentration. So I'll give you an example of when that could occur. Let's take, for instance, a marathon runner. This actually happens during marathons. This is why sometimes we see them collapse. During a marathon, there is actually a phenomenon when they drink too much water. If they drink too much water, their extracellular space gets loaded with fluid. Their intracellular space gets loaded with fluid. That fluid's got to go somewhere. It goes into the cell, and it causes the cells to swell. If the cells swell too much, they burst. And if they burst, you're dead. And so that's where some instances in marathons we see people drop, and that's from too much water. Vice versa, if you're dehydrated, you don't have enough fluid in your intracellular space, all your water is going to leave your cell, and your cell's going to shrivel. And that's not good for it either. So water is a balance, and it's monitored by our cells to figure out how much needs to go in and out. Electrolytes. Can anybody tell me what an electrolyte is? So an electrolyte, according to the definition, electrolytes are chemicals that when dissolved in water create a charged ion. So it's dissolved in water, it creates a charged ion that can release an electrical impulse, or it carries an electrical charge. It's important for the flow of electrical cell signals. It's important for the function of muscle, cardiac, and nerve cells. That's what those cells rely on to release a charge. Our nerve cells and our muscle cells rely on that electrical gradient to function. Without it, they won't function. So we need water to dissolve those electrolytes so they can be passed through our cells. If we don't have enough water, it's not going to dissolve the electrolytes and our cells won't function. So cellular respiration. It's the creation of energy for cells, aka ATP. So this typically occurs in 4 stages. I'm going to go over this very broadly, just so you understand how ATP is produced. I'm not expecting you to know the ins and outs of every single one of these stages. Just know that these are the stages used for the production of ATP, because when we get into aerobic and anaerobic metabolism, that's what this is talking about. Okay? So for aerobic metabolism, anybody tell me what that is?
Oxygenated.
Oxygenated. Oxygen is present. So during aerobic metabolism, there are 3 main reactions that occur. Glycolysis does occur, but it can occur without oxygen. The others, including the bridge reaction, which is part of the Krebs cycle, and the electron transport chain, are all part of aerobic respiration. So to kind of sum this up, we require oxygen in order to efficiently create ATP. The main reason behind that is oxygen is actually really good at holding electrons and then releasing those electrons for energy. It can hold a lot of electrons. So if we're creating ATP, ATP is basically the lysis of a phosphate end, where oxygen then takes those extra electrons down the electron transport chain to release energy. So to show you a comparison, the net result of ATP produced by aerobic respiration is 32 to 34 ATP per glucose molecule. 32 to 34. During glycolysis, which is a form of anaerobic metabolism, that produces 2 ATP. So 32 versus 2. So if we're in a phase of anaerobic metabolism, we're actually expending energy to create energy. Whereas aerobic metabolism, it's not expending really any energy. You're gaining 32 to 34 ATP units for 1 glucose molecule. It's quite a lot. Do I want to talk about anything else there?
Is that why the oxygen thing is like crossed off on these little charts in the book?
Yeah. Actually, there is a picture of that in here. I'll get into that in 1 second. So glucose. Glucose is the building block of our energy. It's the building block of our cell. We need insulin to take that glucose and bring it into the cell. Without insulin, insulin's the key holder, the gatekeeper. It allows glucose to pass through our cell wall and into our cell. So if somebody either is lacking insulin, isn't producing enough of it, or isn't producing any at all, that glucose is just sitting and accumulating in their bloodstream, and it's not going anywhere. So we've got glucose sitting on the outside of the cell. What process of metabolism do you think they're going under if they can't take in the glucose? You got to make energy somewhere. Anaerobic metabolism. And it's using glycolysis. So this is where we get kind of confused. So glycolysis is the process of glycogen, which is stored in our liver, to be converted into a form of glucose that can be then degraded by our cells and produced into energy. It doesn't produce enough energy, and that's the problem. One of the byproducts of glycolysis is pyruvic acid, which is then wasted into lactic acid. So you have a buildup of acid now going inside your system, on top of the fact that you're not producing enough energy. So you can only sustain that for so long.
That comes from someone that's low on oxygen?
No.
No.
That would be for somebody who has no insulin being produced,
Gotcha.
and they're not able to take up that glucose.
So, would anaerobic and glycolysis be the same thing?
2 different things.
Okay.
Because glycolysis does not require oxygen. It's a form of anaerobic metabolism. So yes, they're kind of the same. I'm sorry, I thought you said aerobic metabolism. Anaerobic, yes. Glycolysis is a form of anaerobic metabolism.
Okay.
Because it doesn't require oxygen.
Okay.
And that's basically our only form of energy that we can use, is that process.
Okay.
So, we need insulin for our cells to take up glucose. It allows glucose to be taken into our cell to undergo cellular respiration, both aerobic and anaerobic metabolism. It's used in both of those. Glycolysis is without oxygen, though. So we've already said what happens if not enough glucose is available or not enough insulin is available. Our cells then can't take up that glucose. And it's basically left starving for energy. So just to really kind of hit home with aerobic versus anaerobic metabolism. Aerobic metabolism, think air, oxygen. Aerobic is cellular functions using oxygen. Oxygen is great because during the electron transport chain, it can hold about 10 electrons per oxygen molecule that can then be used to form ATP down the electron transport chain. Without oxygen, then you're relying on glycolysis, which burns 2 ATP to make 4 ATP. So your net gain of ATP from that is just 2, whereas this is 32 to 34. With anaerobic metabolism, your cellular functions are not using oxygen. It creates much less energy, using 2 to create 4, and your body becomes acidic because the byproduct, like we said, is pyruvic acid, which is then broken down into lactic acid. As an acid builds, our pH goes down, we go to a state of acidosis. Any questions with that? There's actually a picture here that explains a little better. So, aerobic metabolism, we have oxygen and glucose that goes into the cell. Our mitochondria then takes those elements. It goes down the processes of bridge reaction, which is part of the Krebs cycle. It also works on the electron transport chain. And a net result is 32 to 34 ATP of energy. If we switch to anaerobic metabolism, our mitochondria is still working, but it's now using the process of glycolysis to produce energy. And glycolysis has a net production of 2 ATP. Why is ATP so important? What does ATP do for us? It's energy. Big deal. What do we need energy for?
Everything.
Everything. Like what? What's everything?
Breathing.
Your heart pumping.
Breathing,
Circulating the blood.
metabolism, cellular production, any type of trauma or injury. We need energy to help fix those issues, right? So ATP is basically our life. Without ATP, we can't do anything. Our cells don't produce. We can't metabolize anything. We can't fix anything. We basically can't live. So that's why we need ATP.
It's basically like the oil on our body, I guess.
Picture it more as like a bank. So you have your currency, which is your energy. ATP is your storage of your energy. So it stores it, it can be used at any time. So you're putting all your currency into the bank, which is the ATP, and then the ATP can then take that and focus the energy on where it's needed, whether it's protein production, working on the cell wall membrane, working on the transports of electrolytes in and out of the cell. That all requires energy. That's what ATP does. It takes that energy and it uses it where it's needed.
My bank is definitely anaerobic.
Are there any like syndromes or diseases that could cause somebody to either produce too much or not enough?
Too much or too little ATP? Probably.
Probably, but nothing that's ever going to concern us.
That's like Dr. House stuff.
Yeah.
Beyond my expertise. I'm sure there is, though. Like malformation of mitochondria. I'm sure there's some form of genetic disease that is a malformation of our mitochondria, or
You probably get a African butt cancer or something like that.
maybe.
I know a kid who has a mitochondrial problem.
Yep.
Yeah, he's like a teenager who looks like a 6-year-old.
What's the name of the disease?
I can't remember off the top of my head.
I'm sure it exists, though.
Is this basically what someone's body's doing when they're doing like a keto diet, like a super low carb, they're cutting out glucose?
That will play an effect on it, absolutely. So a keto diet is focused on proteins and carbohydrates. So those are important for ATP production and the transport of ATP for certain things. And yeah, if you're not taking in, I mean, you can't just completely cut off glucose. You need glucose to survive.
Yeah.
I found
That's where complications come
literally
in.
called mitochondrial syndrome.
Mitochondrial syndrome? All right.
And
I'm glad they got creative in naming
Yeah.
it.
the keto diet doesn't cut all carbs. You're allowed up
Right.
to like 50 carbs a day.
Yeah, yeah.
So you're still getting that basic glucose in there, but the idea is to just get your body to switch over from using glucose mainly to eating your fat. That's the idea of it, and there is a shift that your body does create that makes you feel like crap once your body hits ketosis.
Yeah.
You do feel that way for a few days. But once your body starts producing the fat and the proteins in the way it's supposed to, you'll be fine and more energetic.
When you say 32 to 34 ATP, what is it, molecules or like what's?
So no,
Yeah.
kind of. So think of ATP. That's a better way to explain this. So it produces 32 to 34 ATP. ATP is your energy storage. So think of, the best analogy I can come up with is think of it as a bank, all right? The energy that we use in our body is actually the shift of electrons. Electrons are what produce our electrical gradient to make energy. Our ATP holds that energy. So you need the ATP to hold that energy so it can be used in specific areas. Without it, you have no energy production. All right.
And the difference comes from 32 to 34 comes from cells require 2 ATP for the process to create ATP. So think of it like your paycheck. A cell grosses 34 ATP, but your net gain is 32.
So an example of where we use ATP. In our cell wall, we have different forms of transport chains. So allowing certain molecules into and out of the cell. So that's called passive and active transport, typically of certain proteins that need to go in and out of the cell. They don't just naturally go in and out of the cell. There's actually a channel opening that allows that in and out. In order for that active passage to occur, that requires energy because it's going against the concentration gradient. It's naturally going against what would normally happen, and it requires energy to do that. That's one example of where ATP would be used. It's also used with production of cell walls, breaking down of cellular molecules, that kind of stuff. So think of ATP as just the storage for the energy to be used somewhere. You have to have it. Without it, you couldn't use your energy. So that's the best way I can explain it.
Transportation. Think of it as like armored trucks.
Yeah.
It takes the energy where it needs to go.
Yeah, exactly. Does that make kind of sense for everybody? Don't worry too much about it. You may get one question during your NR EMT exam on basically what's the difference between adenosine triphosphate and adenosine diphosphate. Try 2 phosphate molecules, try 3 phosphate molecules, 2 phosphate molecules. Makes sense. You're going to be asked more on the difference between aerobic and anaerobic metabolism. So knowing aerobic produces more ATP than anaerobic, that you will definitely be asked on. Okay. Yeah. So the vulnerability of cells, organs, and organ systems. So many diseases alter the permeability of the membrane. Ineffective cell membrane can allow substances into the cell that shouldn't be there. These substances can interfere with the regulation of water. It can also interfere with the metabolism, the effect of mitochondria, or ribosomes. So things that shouldn't be in there are now able to get in. Can anybody think of some examples that can affect the permeability of our cell membrane? There's 3 that you should know.
Lack of electrolytes.
You're not far. You're close. I'll give you 1. Temperature. Temperature, either too hot or too cold, denatures proteins. Proteins are within our cell wall. If those proteins become denatured, anything can go in, anything can come out. So temperature is 1. 2 more.
Infection or destruction?
It's a byproduct of an infection. pH.
I was just going to say pH level.
Acidotic, alkalotic. pH denatures proteins. So.
Is that why you can only go, what, like 5 in either direction? Because your cells won't function?
Yep. It denatures your proteins. And your proteins are a major component of your cell wall. Without your proteins, your cell wall doesn't function. So pH is a big one. Temperature. And one more, I don't expect you guys to know this one, ethanol. So alcohol denatures our proteins and breaks them down. Too much alcohol will actually dissolve your cells. By that point, you're not going to survive anyways because that's an astronomical level. But understand that that's one of the things that can actually denature your cell walls is alcohol. So temperature, pH, alcohol.
That's what alcohol poisoning is?
Very mild form of it.
Yeah.
Yeah, alcohol poisoning is more of, it's just such a concentration of alcohol in your bloodstream. It kind of denatures your red blood cells, but it puts you kind of to a state of comatose because you're not producing oxygen, you're not taking in oxygen like you're supposed to. Your cells actually switch to anaerobic metabolism because your alcohol concentration is so good. We go to those from time to time.
The breakdown is more or less long-term use of ethanol.
Yeah.
Yeah. So what is one major organ that alcohol affects in our body? Liver. Alcohol damages our liver cells, right? Because what was that one component of our liver cells that helps detoxify our fluid, our blood? Already said it.
Smooth ER.
Smooth endoplasmic reticulum. Alcohol is one of the things that can damage smooth endoplasmic reticulum, and it's abundant in our liver. So if our liver starts shutting down, our whole body's going to shut down. Bye, Joe.
Bye.
Where did my mouse go? There it is. Okay, let me just make sure I'm not forgetting anything here. TTP, we covered that. Okay, any questions with any of this stuff before we move on from it? Pretty straightforward. The one thing I did want to mention about this. When we're talking about fluid, one of the treatments we do in the field for patients is fluid resuscitation. Okay? I don't know if Joe went into it a little bit with you guys. Did you guys go over the understanding of hypertonic versus hypotonic versus isotonic fluids?
Yes, we did. There's a little whiteboard there.
Okay. Just as long as you have the general understanding.
4 weeks ago, and
Yeah,
it's
it was
about
a while
10-minute.
ago.
10-minute spiel.
Yeah.
Okay. So the one thing I will mention about it.
Because it was the pH of the fluids administered.
If we remember the process of osmosis, we have a semi-permeable membrane, which is basically our cell wall. So these represent our solute. Water is our solvent. Maybe call it some 2 trucks. Okay. So we have a large amount of solute, which would basically be sodium, chlorine, whatever. Very little water. We have a lot of water and very little solute. Which way is the water going to shift? From a higher concentration to a lower concentration. Does that make sense? That's the process of osmosis. Now, if we take that into consideration when we're giving fluids, we have 3 main fluids: isotonic, hypotonic, and hypertonic. Okay. We'll start with hypotonic. So hypotonic fluids are fluids that have very little solute concentration. This is a symbol for concentration. So very little solute concentration and higher water concentration. Okay? How do we think that'll shift the fluid into and out of our cells?
If there's high solute in the cells, it'll shift water into them.
Into the
So you
cells.
get that when they're excessively dehydrated.
There you go. So it causes our cell to take in water. Because there's more solute in the cell than there is outside the cell. Now vice versa, hypertonic fluids.
You're going to be pulling water out of the cell to put solute in. So you do it for somebody who is desalinated themselves by drinking too much water. Right?
In a nutshell, typically we use this for patients who undergo TBIs, traumatic brain injuries. So one of the effects of a traumatic brain injury is it increases increased intracranial pressure, the shift of fluids basically in our cranium. So we don't want that extracellular fluid to shift into the extracellular space in our brain because that's going to increase ICP, which is then going to kill brain tissue. So we use hypertonic fluids to pull that water out of the extracellular space, allowing our brain basically not to swell and prevent it from swelling and causing brain damage. That's kind of the main reason we use hypertonic fluids. So this one causes fluid to, hello.
I apologize.
It's okay.
I didn't get back to Essex Junction until like 18:30
Oh,
from Rutland.
yeah, that's cooking. No worries.
A long day.
So yeah, hypotonic forces fluid into our cell, hypertonic forces fluid out of our cell. And then if you can guess, what does isotonic do?
It's the exact same concentration.
Same concentration, so it's not going to force fluid in, it's not going to force fluid out. An example of this is normal saline. And lactated ringers. Those are isotonic fluids. So if we're not looking for a fluid shift, we're just looking to increase volume, those are the fluids we go with. Make sense? Alrighty then. Does anybody need a break before we get into this?
I think you should have a break.
Okay.
Yes.
Take a break. Pulmonary system. What can go wrong with that?
Everything.
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 So the cardiopulmonary system is made up of the respiratory and cardiovascular systems. They work in unison together. Kind of important because those are part of our vital organs. The main job of the cardiopulmonary system is to bring in oxygen into our body, make sure that oxygen is delivered to our cells and tissues, and then removing the waste products from those cells and bringing them back to the lungs to be expelled. Any breakdown of any portion of this can result in a system failure and death. Ultimately, that's what death is. So our body works to take in oxygen. Our lungs take in oxygen. The oxygen is then crossing the the capillary membrane bed into our arteries, or capillaries, which then goes to our heart. Our heart takes that oxygenated blood, delivers it to our tissues. Our tissues take in that oxygen, create energy, and a byproduct is CO2. The CO2 then goes back into our bloodstream, brought back to our lungs, and exhaled out. What can go wrong with that? So first, just a general understanding of our airway, our respiratory system. So our upper respiratory system consists of our oral airway, our nasal airway, our pharynx, down to our larynx. Our larynx is where our vocal cords sit, and that goes down into our lower airway. So this is a picture of our lower airway. You've got our larynx down to our trachea. Anybody remember what that initial bifurcation is right here? What that's called?
I forget how to pronounce it.
It's cool, man.
C-A-R-N-I-A?
Carina.
Carina.
Yep, that's the carina. So remember that because that was actually on my test question when I
It's
took
on the
the
practice tests.
It is.
A lot, which is why I know it.
Yeah. We use the carina kind of as a landmark. At the paramedic level, we use it for our intubations, making sure we don't go too far. Because if we're putting a tube down somebody's trachea, a lot of times what can happen is that tube will actually go down into the right bronchial. So we're only inflating one lung as opposed to two lungs. So is that bad? Kind of, but at least we're getting air in and out of the lung. So that first bifurcation is the carina. That breaks off into our right primary bronchial and our left primary bronchial. And then those branch off into trees or branches to our secondary bronchioles, tertiary bronchioles, and so on. Yeah. So at the end of our bronchioles, we have these little grape-looking structures. These are called alveoli. So alveoli is where the air accumulates. This is where capillaries kind of encompass. You can see on that picture on the right, capillaries encompass around the alveoli. So oxygen can pass from the alveoli into the capillaries, and CO2 can cross from the capillaries back into the alveoli. What can go wrong with that? What about COPDers? Their big main problem with COPD comes down to their alveoli. So if we look at a normal alveoli, which you're looking at on the right, it's blown up nicely, it's got good surface area, and it's covered by capillaries around its surface area for that gas exchange. COPDers chronically develop mucus in their alveoli. Mucus does not allow oxygen or carbon dioxide to cross into the capillaries, and the surface area of the alveoli increases so much that contact with the capillaries decreases. So it's not good contact with our capillaries, doesn't allow good gas exchange from one to the other. Pneumonia. Pneumonia is a perfect example. Seen often in our elderly population. What is pneumonia?
Infection in the alveolar, well, it's liquid in your lungs, isn't it?
Yep. It's an infection in our lungs, typically caused by a bacteria or a virus, and it's just an accumulation of fluid in our lungs, in our alveoli. Fluid's not good in our lungs, not supposed to be there. So if we have fluid accumulating in our lungs, oxygen gas exchange is not occurring. And we can actually hear that when we auscultate them. So understand kind of the general function for the capillaries and the alveoli. You can see on the picture on the left, around the bronchioles, you have smooth muscle. Smooth muscle contracts and relaxes to open up our airway and contract in need, typically during a parasympathetic response, to withhold oxygen and CO2. What's a condition where the bronchioles become narrow and contracted?
Asthma.
Bronchitis, asthma. Absolutely. So when you hear somebody with an asthma attack or bronchitis, we hear that loud wheezing, sounds like a whistle. That's exactly what you're hearing, is the bronchioles contracted down to the point where it's not allowing air in and it's not allowing air out. That's what you're hearing. So for an airway, number one, you must have an open patent airway for the system to function. Okay, so when we're documenting, this is one of the first things I put in. Patient maintained patent open airway. So when we talk about the upper airway, some issues that we can experience with the upper airway includes foreign body obstructions, so choking. Kids especially, kids love to put things in their mouth, so choking hazards definitely occur. That's called a foreign body obstruction. Okay. Infections. What's an infection of an upper airway? What is it?
I can see it. I'm just.
Tonsillitis.
Tonsillitis is one. Because our tonsils are up in our upper airway. Strep throat, yeah. If it becomes inflamed enough that it closes down our airway, not quite as common.
What about mumps?
Measles and mumps.
Croup?
Croup is lower airway.
RSV.
RSV is lower airway. There's one more. Prominent in kids.
Starts with E.
It does. What's the little flap that goes up and over our trachea?
Epiglottis.
Epiglottitis. So inflammation of the epiglottis. It used to be more common in kids. Now it's actually less common in kids and more common in adults from vaccines.
The shift?
So vaccines, the prevention is actually shifted, so it's seen more in people that aren't vaccinated against certain viruses. That's why you see it.
Vaccines.
So that's why we're not seeing it more in kids. The most common sign that we see for epiglottitis is obviously shortness of breath, but excessive drooling. So in kids, if you go to a kid that is excessively drooling, appearing short of breath, not talking, not acting appropriate, one of the major risks is epiglottitis. Epiglottitis is super hard to treat and super hard to fix. There's nothing I can do at the paramedic level to fix it. The only godsend I can do to try and give them an airway is to actually do a trach. I really don't want to do that on a kid. So that's our only
What do they do
saving thing.
surgically to fix it?
There's nothing really you can do surgically. It's just steroids and antibiotics, antivirals. Because to try and intubate around the epiglottis, because it's so swollen up that it's actually so big, it's over the trachea when it's not supposed to be. And it's not allowing air in or out.
How often does that happen?
It's not very often, but something you should be aware of. That can happen. So that's an example of infections. Trauma. Any form of oral airway, neck trauma, definitely.
Would that be common in like?
MMA.
Well, I'm thinking what kind of like car accidents you go to all the time. If somebody's seatbelt wasn't positioned correctly, could that be causing more of a?
So the more common you'll see for upper airway in trauma is strangulation or hanging.
Okay.
Those are the two most common. We'll see with trauma, or some form of blunt or penetrating trauma that goes into their airway. That's why we ask them to open their mouth for tooth fragments that broke off, potentially could get lodged. Same thing with their tongue. So your tongue, when you become unresponsive, you develop what's called a floppy tongue, and where your tongue wants to go, it's back into your throat. So that's why, especially at the EMT level, one of your adjuncts you can use is a nasal or oral adjunct. That's what that OPA, or oropharyngeal airway, is doing, is it's actually going around the tongue and keeping it from going back into your throat.
So a nasal airway wouldn't help from the epiglottitis either, it wouldn't get around it enough?
Nope.
Don't go in far enough, right?
Yeah, it doesn't go down far enough because your epiglottis is down towards your trachea and your larynx. Even intubation, for me to intubate somebody, it's actually a contraindication for me to intubate somebody because you can aggravate it and make it worse. So it's basically, okay, you're breathing, let's go. You're not going to stay and play with that.
But if you suspect they're not going to be breathing, that's definitely grounds to call a paramedic.
Yep. Yep, because if we need to do a trach, sometimes albuterol will work to try and open up. It's not going to fix the epiglottitis, but it'll actually open up their bronchioles a little bit to try and allow some form of air in and out.
High flow O2?
Yep, high flow O2. Concentrate as best you can. Any questions with upper airway issues? Those are the main ones. So the lower airway. I think I talked about this last week, explaining tidal volume, minute volume, that kind of stuff. So anybody tell me what tidal volume is?
How much the amount of air you move in one respiration in and out?
One normal inspiration, expiration. So not taking a deep breath, not exhaling deeply. It's just one normal inspiration, expiration. Anybody tell me what the normal volume moved by an adult? 500 to 600 milliliters. How much volume is in our BVMs?
Should be a liter to 1500.
A liter. So an adult BVM is about a liter of air. So we don't need to squeeze that entire bag to move air into their lungs. We're giving them double what they need. So that's why we do when they squeeze the bag, just until we see chest rise. Once we see chest rise, the lungs have expanded, we're good. We don't need to go more. So you do need to understand the definition of tidal volume. Volume of air moving in and out of the lungs during one breath. So one breath cycle, inspiration, expiration. With that, you need to know minute volume. So minute volume is the amount of air moved in and out of the lungs during 1 minute. So we can figure that out based on their respiratory rate and their tidal volume. We don't have a tool to measure tidal volume in the field.
But you can estimate it.
Yeah, in general you can. Has anybody ever seen those spirometers if you've ever been admitted to the hospital?
Yeah.
One of the things they make you do is breathe in that little plastic thing, and they tell you, all right, try to get the bubble up to this point or whatever it is, an arrow. That's actually measuring your tidal volume. So we can't do that in the field, but you can kind of estimate based on what you're hearing, what you're seeing with the patient, and then taking in your respiratory rate. Your normal minute volume.
That's what I was thinking. It's like 5 to 8 or
Yep.
up to, yeah.
5 to 8 liters per minute. So that's the amount of oxygen you're taking, or air you're taking in 1 minute. So know those two definitions, tidal volume and minute volume, and the difference between them. So, what can go wrong with this? Any change in tidal volume or respiratory rate reduces your minute volume. So, the amount of air you're taking in and exhaling, or your rate of respirations will affect your tidal volume. So, respiratory rate dysfunction occurs anytime something interferes with their minute volume. So, I threw this picture in here. This is comparing a normal airway versus a patient with an asthmatic airway and a patient with a history of asthma experiencing an asthma attack. So a normal airway, you can see on the left, fairly open. The bronchioles are constricted. The bronchial walls aren't thickened. There's not an abnormal amount of mucus being produced. It's a good area for air to move in and out. A patient with a history of asthma typically has a thickened bronchial wall, and during an asthma attack, the smooth muscle around the bronchioles becomes constricted, and it clamps their airway down even more. So what is that going to do to air during an asthma attack?
You're not getting very much of it.
You're not taking it in, and you're not expelling it out.
It stays in there and
Not good air
not
exchange.
good. No.
Yep. So what's going to build up if we're not moving air?
CO2.
Carbon dioxide. Yep. So we're not taking in oxygen, and we're not expelling our carbon dioxide.
This is a cascade effect, and starting from there, lactic acid. And
There you go. You guys are learning. I like it. Any questions with that?
So asthma affects the bronchioles, not the alveoli.
It affects the bronchioles more than the alveoli.
Okay.
Because another part of asthma, and especially COPDers, is the production of mucus. So mucus can actually build in our alveoli as well during an asthma attack, more or less during COPD exacerbation and CHF. Asthma's main component is the constriction of the bronchioles. And we hear that when we listen to lungs, and we hear that loud pitch wheezing. That's what we're hearing. So we need to give something to fix that. We use inhalers, albuterol, that type of stuff works as a smooth muscle relaxant to allow those bronchioles to open back up. Aye. Questions, Derek?
No, nothing.
COPD people,
Yep.
that's the damage to the alveoli mainly, so if there's not the exchange, smooth muscles, the capillaries going by there. These are from smoking,
Yep.
from exposure to gases, any other normal,
Underlying conditions can cause it as well.
whole bunch of things.
It's mainly an accumulation of it's a chronic condition.
Those are the two big differences between asthmatic and is asthmatic a COPD person or?
So you can have COPD and asthma.
Yeah.
It doesn't necessarily mean you're going to have asthma and COPD.
Okay.
So COPD, chronic obstructive pulmonary disease, is an accumulation. It's actually two components, bronchitis and emphysema. Two main things. Those two things make up COPD. So when somebody says, I have emphysema, you have COPD.
Okay.
Okay?
Yeah.
Bronchitis is just a general inflammation of the bronchioles. The bronchial the bronchial walls thicken, and the bronchioles produce excessive amounts of mucus. That's why they typically kind of have wet lung sounds. That's actually can be a normal variant for them. That chronic cough that you hear, the COPDers, that's the overproduction of mucus in their airway. Okay? Emphysema affects our alveoli. So normal alveoli have good contact with capillaries, There's this product called surfactant, spelled like this.
It's basically just lung goo, right? Keeps everything.
What's that?
It's just lung goo.
Yeah, lung goo. That's what keeps your alveoli expanded. Lack of production of surfactant causes your alveoli to either shrink or actually become what would normally be one alveoli and another. They basically kind of merge into one.
With bronchitis, like, I had bronchitis years and years and years ago. You develop it and you're done with it, and you never get it again. So, emphysema, once you've got it, you've always got it. Okay.
Yep.
Also, bronchitis can be super chronic without it being COPD or emphysema.
It can be, if it's on its own. But if you have chronic bronchitis and emphysema, you have COPD.
Yeah.
That is COPD in a nutshell. I'm trying to think. Does the emphysema portion make sense? So it's basically, emphysema is when your alveoli either expand too much or shrink. They're not producing enough surfactant. That is the main thing of emphysema, is it's not producing enough. And because of that, when they expand, they don't have good contact with the capillary membrane bed, and that doesn't allow good gas exchange. So that's why they become short of breath pretty easy. Make sense?
Mm-hmm.
Okay, so starting from the top. One thing that can affect our minute volume is our respiratory rate. If we have a disruption in our respiratory control center, which comes from our medulla in our brain, our respiratory rate can either become irregular, decrease, or become apneic, or increase and become too fast. So somebody who has a traumatic brain injury, a cervical spine fracture, that all affects our respiratory drive and our respiratory rate. One of the things we actually look for in a TBI is a respiratory pattern. It's called Shane-Stokes respirations, and you'll learn that when we go into airway. Anybody ever heard of Shane-Stokes?
Yeah.
Did you have a case?
Sort of. So 8 years ago when I first started taking the EMT class, we had just talked about the Shane-Stokes syndrome.
Yep.
And that weekend I was at my brother's wedding, and the following day my father had some medical issues. We brought him to the hospital, and I identified his breathing as being very similar to Shane-Stokes.
Yep.
And long story short, he ended up having brain cancer. But that was like a major
indicator,
a major symptom, major indicator.
Yep.
And that's why I didn't do the class 8 years ago. But yeah, that was.
Yeah, it's not very often we see Shane-Stokes. It's kind of a late sign to traumatic brain injuries. It may be an early sign for prolonged things like cancer.
It was actually a pretty late sign for him.
Yeah.
I mean, he was having vision issues. He was having breathing issues.
Yeah.
And he had other issues. He had diabetes, and his blood sugar was in the 600s. So I mean, there were a lot of issues, but but the breathing was one of the things that I picked up on, and I mentioned it to the doctor, and the doctor was like, "Well, yeah, that's why we want to screen him for, a stroke."
Yep. Yep, that can be one of the signs of stroke, definitely. So for those that don't know what Shane-Stokes breathing pattern is, it's basically it's an irregular respiratory pattern. Once you see it for the first time, you'll never forget it. I've had it with TBIs, I've had it with strokes. It's basically when it's an intermittent pattern of deep, irregular respirations followed by periods of apnea. So they're shallow, deep breaths, and then periods of apnea. Shallow, deep breaths, periods of apnea. First time you see it, you won't forget it.
So I've got a picture here on my phone.
Mm-hmm.
One of the machines that he was on was measuring his breathing.
There you go.
Pattern.
Yep. Everybody can see the deep respirations in there, followed by the shallow breathing, followed by the periods of apnea, where they stop breathing. That's an indication
Pass that around.
of traumatic brain injury, a stroke, some form of abnormal brain function.
Reminds me of shallow breathing when you got tanks on.
Mm-hmm. So that's what Shane-Stokes looks like. And that's all affected by our respiratory control center. So our medulla telling our body, take a breath.
Is it chain?
Shane-Stokes. Spell here.
Think of the Stokes basket. Oh, really? That's all I remembered it.
Yeah. So, like big deep breaths.
Chain stokes.
Kind of like forget how to breathe in your body. Like this doesn't.
That Shane Stokes. We'll cover that more. You're not going to be quizzed on it in this chapter. That's more in when we get to airway.
And it, like, I wasn't even thinking, like, I wasn't even thinking along those lines, and I saw it on the monitor.
Yep.
And the doctor hadn't noticed it yet, and I was like, hey, I see this, and he goes, yeah, we should really,
Scan.
we should do a scan
Yep.
for a stroke, and that's how they have cancer. But, like, once I saw it on there, I could see it, like, physically on his body. Like, he would take a real deep breath and gradually go down to nothing.
Yep.
And then he would literally stop breathing for
Yep.
4, 5, 6 seconds, and then have a giant breath again.
Yep.
And
Absolutely.
it went on for hours. So.
Yeah. That's his control center
Yep.
being affected.
Yep.
Not following the pattern it needs to. There is actually multiple different respiratory patterns that we're going to get into. Examples include Biot's, Kussmaul respirations. What are the ones are you guys going to cover? Biot's, Kussmaul, apnea. I think those are the 3 main ones that you guys need to know. And we'll get into those when we get into respiratory emergencies. So, any disruption of the respiratory control center affects our respiratory rate, our respiratory depth. Any event impacting the function of the medulla oblongata can affect our minute volume. So, infection, drugs. What's the most common drug that we see affect our respiratory drive? Opioids. There you go. I just hit my 10th opioid overdose this last week.
You get a pen?
Wow.
Yeah.
No, they typically avoid the needles.
Yeah. So opioids are definitely on the market right now, unfortunately. It's pretty bad.
It's because we're so close to Canada. There was a whole, that guy from Harold and Kumar? I don't know which one of them, the skinnier one. There's like a Netflix thing that he hosts. And the whole first episode of the show was talking about how Vermont was one of the worst states for narcotics and opiates because they easy to get.
Yeah, I'm sure it's everywhere. I mean, it seems bad here because we're a small town, but
yeah.
My brother lives in San Francisco, and there's overdoses like every day.
Yeah. I've given out more Narcan this year than I have in my entire EMS career, and we're only 6 months into this year.
Well, I think there's so much of the pandemic really impacted people's mental health and access to support systems.
Absolutely.
There was also a decrease in availability because people weren't out and about. And now that things have kind of opened back up, there's that access again, and we never dealt with any of the issues or reached back out to reestablish support.
Right.
So there's a lot of relapsing right now, which is actually more problematic for overdoses than regular users.
Yeah,
Explain
unfortunately.
to do your job. We just got an interesting report based on the increasing overdose.
Ugh. We're definitely seeing it here.
Like, it's not just overdoses too, it's people struggling with alcoholism.
Yep.
My grandfather has been through
Alcoholism, depression, mental health in a basically in a nutshell.
Back, and in Vermont less than a year, and he's been in rehab like 3 times.
Yep.
Because he keeps relapsing.
Mm.
Being
Yeah,
cooped
that's
up
not
in
good.
your apartment by yourself, like, what else are you gonna do?
Oh, absolutely, yeah. The pandemic definitely played a big role on it, unfortunately. So yeah, any one of these things can affect our medulla oblongata. When we talk about infection, one of the big things, meningitis. Anybody's ever heard of meningitis?
My little brother, he was diagnosed with spinal meningitis actually.
Yep. So meningitis is a big one. It's an infection of our meninges. It affects our cerebral spinal fluid. It definitely affects our medulla oblongata and our respiratory drive. Drugs, we already talked about those. Any toxins we can think of? It's 2 that come to mind for me.
That affect your ability to breathe, or
Carbon monoxide.
Carbon monoxide doesn't really affect our medulla oblongata very much, but it's definitely a respiratory system issue.
Oxygen.
One. What's that?
Oxygen level in the air.
Yeah, oxygen
With smoke
concentration.
inhalation?
What's that?
Smoke inhalation?
What about smoke
Would
inhalation?
that be pollution?
So cyanide poisoning, that affects our respiratory drive. And there's one other form of poisoning. There's one other. Typically is found on farms.
Methane.
Oh, the,
I forget, the one with the skin.
I can't remember.
Organophosphate
Oh,
poisoning.
yeah.
That's it.
Organophosphate. So that's the other one that affects our respiratory drive. So those are tricky. The treatment for those is a lot of atropine. We don't carry enough atropine in this entire station to fix it. But that's one of the major things. Trauma, TBIs, that can definitely affect it. Strokes, any of that type of stuff will affect our respiratory drive. So, disruption of pressures. This is something common we see in traumas. So when we talk about pneumothorax, hemothorax, tension pneumothorax, this is all dealing with the collapsing of a lung. Okay? So, if we take a hole, we put a hole in our chest wall, that creates a thorax. What does air pressure do into our lung cavity? If we start pulling in air and that air is not being expelled out.
Your lungs can't
It
expand.
displaces.
So that air is going to build up in our lungs, it's going to cause our lung to collapse, and it's going to push on everything inside, right? That's called a tension pneumothorax. So when it pushes enough that it creates tension on our heart, typically in a late sign we'll see tracheal deviation, where the trachea actually shifts. That's a really late sign. There's only one way to fix that. It's a
Crack the
closed
chest.
tension pneumo. What's that?
Crack the chest open.
Nope.
Needle decompression.
Needle decompression. So we actually take a needle, we put it, depending what site we choose, 2nd or 3rd intercostal, or the surgeons like to go 5th or 6th intercostal, and we punch a hole through their chest wall, and that allows that air to escape out. Let's say it's a gunshot wound or a stab wound, and they have a hole. What's another treatment we can use?
The
Occlusive dressing 3 sides.
yes.
Occlusive
Dressing
dressings.
that
With
can
it
allow
down.
air
Yep.
out but not in.
So chest seals, those have a little valve inside them. It allows air to be expelled out. It doesn't allow air to come in. That's the main job of those. So any of those pressure changes within our lung cavity can cause that lung to collapse. What holds our lung up against our pleural space?
Would it be like the diaphragm? Isn't that-
Nope.
Negative pressure.
Pressure plays a role, but there's actually a specific substance that holds our lung up against.
No, it's the pleural fluid.
What's the name of it?
Yeah. I'm drawing a blank again.
Visceral pleura. Okay, so there's actually a fluid that butts up between our lung and our pleural cavity, and that keeps our lung up against that pleural cavity. So as we take a breath in, our lungs expand, air rushes into our lungs, and as we exhale out, air rushes out of our lungs naturally through pressure gradients.
Is that way if you've got like a stab or a gunshot wound and you started getting that bubbling?
In
it's
the
not-
chest
it's-
wall?
It's not blood, but it's liquid. So that's
Well,
what that-
it's blood and liquid,
well,
typically. Yeah, so if you're seeing that bubbling, bubbling's actually good because that means air's escaping out,
you know.
which is a bonus. We want air to escape out. And that's where we do a chest seal over that. We can have closed pneumothoraxes. So an example of this, people can develop a spontaneous pneumothorax. That's exactly what it's called. It just spontaneously collapses. That can be seen in COPDers. People with chronic lung conditions are at risk of developing that. And basically the main symptom for them is kind of sudden onset shortness of breath, unprovoked, and chest pain. Those are the two main symptoms for that. And how we diagnose that is just by listening to their lungs. I'm hearing great lung sounds on this side. I'm not hearing shit on this side. There's no air movement on that side, typically from a pneumothorax.
You start to see.
You can,
Flail, yeah.
yes,
Yeah.
good point. So looking for equal chest rise. Equal chest rise on both sides. This side's expanding, this side's not. That's telling you that this lung's not inflating. It's because of a pneumo. So understanding those differences, a hemothorax is when blood accumulates in the pleural cavity. So hemo being blood. So hemothorax. Those are the main things. And the only way to fix that, to re-expand the lung, is to do a needle decompression or a chest tube. That allows that lung to inflate based on the pressure gradients. That lung will over time expand and butt back up against the pleural cavity.
In a closed pneumothorax, where's the air coming from?
It doesn't necessarily that mean air is being entrapped in that pleural space. It's just that the lung isn't butting up against that pleural cavity, so nothing's holding it up against, and it's just remaining collapsed.
Okay.
So even inflating that lung isn't going to keep that lung butted up against the pleural cavity. It needs that basically surfactant to keep it up against the pleural space.
And the fluid that connects it, the viscera, is gone or moved,
diminished,
so it won't reconnect. How are they going to reconnect to get that?
Over time, use a chest tube.
Yeah.
That chest tube will allow that lung to expand again, and then over time it'll butt back up against that
Your body
pleural
will
space.
reproduce.
Yeah.
Okay.
Depending on what condition you have. But in a nutshell.
Why did they do the chest tube instead of a needle decompression? Is it just allowing
Good
more-
question. So a needle decompression is temporary. That buys us about 10 minutes of time, because over that 10 minutes, you got to think that we're going through muscle tissue.
Yeah.
We're going through our pectoralis major, which is a large muscle. So that muscle, it just went through trauma. It's going to contract, and it actually contracts enough to close off that catheter that we leave in. And then fluid also builds up on that catheter too. So it realistically buys you about 10 minutes.
Okay.
And that's why some traumas, if we're coming from way out and we're doing that, we're doing multiple needle decompressions. So that's the main reason. A chest tube's a little more permanent because it's a bigger tube going in that can sit there. And with that, they're also doing suction to try and pull air or blood, whatever's accumulating in there. So
I helped transport a patient once that had pneumothorax, and of course we didn't have EMTs at that point, or paramedics at that point in time, so there was no needle decompression. But when we got to the hospital, the ER was really busy, and they did a chest tube, and they had me literally pushing on the other side of the patient. Because when the surgeon was trying to push that chest tube in, he was pushing the patient across. And I thought, like, I just, it's always stuck with me, like, it was such a violent procedure.
it is. Yeah, when I
So
worked in
that's
the
why I was
ER,
like,
I've been
why
part of
would
them.
they, you know,
It's
but
so, yeah,
it's more
when
fun.
we use, for needle decompression, we're using a 14 gauge needle, which really isn't that big for a chest tube. Chest tube, they're using tubes that are about that big around, and they have a huge rod that's got a pointed end. It's not sharp, but they have to use that to punch through the pleural cavity. They're kind of cool to watch. You can YouTube them.
Yeah, that's good.
Sure.
Oh, it was really cool, but it was also like, I never want that done.
Wilderness.
Well, if it's that or saving a life.
Right.
Well, yeah.
I mean, you can YouTube wilderness medicine. Like, what do you do in a situation if you're out in the middle of nowhere and you need to create a wet chest seal? It's using a series of straws to basically create your own chest tube. So when you put the straws through a water gradient, the one I can think of, if anybody's seen The Good Doctor.
Yep, I was just
There you go. He created his own using Jack Daniels.
Yep.
And that's exactly what he did. He created a wet seal so air couldn't go into the lung cavity and only air could be expelled out. That's exactly what he did. Treating attention pneumo. Okie doke. Any questions with that? Fun stuff. All right. Disruption of lung tissue. So trauma or medical problems can compromise the ability of alveoli to exchange gases. Less oxygen gets in and less carbon dioxide gets out. That can result in low oxygen levels, or hypoxia, and high carbon dioxide levels, which is hypercapnia. So a good example of this is congestive heart failure. Okay? Flash pulmonary edema. Pulmonary edema. So pulmonary in our lungs, edema, fluid building up in our lungs. If we have fluid build up in our lungs, that prevents that gas exchange of oxygen going into our cells and CO2 coming out of our cells, or coming out of our vessels into our lungs. So anything that can compromise that is a condition, whether it's trauma, pneumonia, congestive heart failure, anaphylaxis, all that stuff can cause that. So the body attempts to compensate for gas exchange deficits. So we have chemoreceptors that detect changing oxygen and carbon dioxide levels. Those chemoreceptors sit primarily in our medulla. They also sit in our aortic arch and our carotid arteries. So the chemoreceptor's main job is to detect pH level changes. The ones in our aortic arch and carotid arteries also detect O2 levels and CO2 levels, but primarily for arterial blood. So if it's detecting pH, what's an acid that's part of our cellular respiration that's produced that can alter pH levels? Give you two options, oxygen or carbon dioxide. Carbon dioxide. That's what it's looking at. It's detecting our pH concentration, and it changes our respiratory rate based on that pH. So the higher our carbon dioxide levels, the lower our pH goes. Take, for example, an opioid overdose. I come back to these because this plays right directly into that. We have somebody over an opioid overdose. They're not breathing, right? The respiratory rate's like 2 to 4. Carbon dioxide is building up in their bloodstream. As carbon dioxide builds up, their pH goes down. Unfortunately, they don't have a way to compensate for that because they've got opiates sitting on their opioid receptors. And those are stimulating their brain to say, parasympathetic response, you don't need to breathe, and you don't need a blood pressure, and you don't need a heart rate. Not good. Kind of defeats the purpose. So when we wake them up with Narcan, we displace those opioids on the opioid receptors. Finally, their brain stimulates and says, hey, I got to get rid of this CO2. I got way too much built up in here. So when they wake up, the first thing they do is breathe fast and rapid, deep and fast. And that is the result of their chemoreceptors monitoring their pH levels. Does that make sense? That's how our chemoreceptors function. Anything that affects our chemoreceptors will affect our respiratory rate and our respiratory depth. Yeah. The one thing I do want to talk about on this is COPDers. COPDers actually breathe differently than we do. How so?
They don't, their body doesn't tell them to breathe based on,
Oxygen level.
doesn't tell them to breathe based on needing to expel carbon dioxide.
Good. So our body, normally without the presence of carbon dioxide, we are stimulated to breathe based on our CO2 levels. More CO2 decreases our pH. Our medulla recognizes that and says, hey, pH needs to go up, breathe faster. Unfortunately, COPDers chronically live with high levels of CO2. All right, that's part of the process of COPD. Because of that poor gas exchange, they chronically have higher levels of CO2 in their bloodstream. So their body over time recognizes that and now relies on their O2 levels to stimulate their breathing. So too high of O2 levels tells their body, okay, I've got a high concentration of O2, I can slow down my respiratory rate, and I can slow down my respiratory depth. Too low CO2 of O2 levels increases their respiratory drive. Okay, that's the alteration. So if we go to a COPD patient and we start flooding them with high amounts of oxygen, you'll actually watch their respiratory rate drop because of their body responding, saying, hey, I've got a ton of oxygen in here, I don't need to breathe. Make sense?
So it's counterproductive.
Over time.
To some extent.
Yeah.
They've probably been on O2 anyway.
So nasal cannula versus BBM.
Start small, work your way up.
Yeah.
Exactly. So with COPDers, if I go to a patient with COPD exacerbation, typically they're calling because they're feeling extremely short of breath and they can't catch their breath. You know, they're breathing deeply, breathing rapidly, and they're just not getting enough air. So in those instances, I'll say, all right, let's try some oxygen, let's try a nebulizer treatment to open up your airway, start getting some oxygen back into your system. If I'm seeing that they're to the point their oxygen saturation is up around 99 to 100%, which is high for a normal COPDer, then I can say, okay, I'm not seeing a perfusion issue where oxygen's crossing that capillary membrane and into their blood vessels. I'm trying to figure out what else is causing their shortness of breath. That'd be a pneumo.
Cardiac.
What's that?
Cardiac.
Cardiac, yep, absolutely. So just something to keep in mind when you're treating COPD patients. It doesn't mean never give them oxygen. It's one of our first line treatments is oxygen. Makes sense? Okay, the blood. So what can go wrong with the blood? There are 4 main parts of the blood. We have plasma, red blood cells, hemoglobin, which is the oxygen carrying component of red blood cells. We have white blood cells and platelets. So those are the 4 main parts when we talk about blood. Typically when we think of blood, we just think of red blood cells. Red blood cells are just a portion of whole blood. We also want to consider plasma, which is kind of the extra fluid within the blood. White blood cells, which are used to fight infection, and then platelets, which are used to form blood clots. So plasma affects oncotic pressure. Proteins in plasma attract water away from an area around the cells and pull it into the bloodstream. So we have a higher concentration of proteins in our blood plasma that will pull water from our extracellular spaces into our bloodstream. And I have a picture of this to show you. The main thing you need to know on this is just the difference between oncotic pressure and hydrostatic pressure. So hydrostatic pressure is the opposite, when water is pushed from our blood vessels back into our cells. Problems with these proteins can cause an imbalance. So too high of a concentration or too low of a concentration of proteins will shift that water. This is basically what the two look like. So hydrostatic is going from our vessels out to our interstitial spaces, and oncotic is from our interstitial spaces back into our blood vessels.
Do we have that graphic, actually?
You do not. I pulled this one. You can take a picture of it with your phone if you want.
And lose it in my camera roll? I should
Save it to your favorites.
If you Google oncotic versus hydrostatic, this is one of the pictures that come up. But just to give you a general idea of what these mean. So what can go wrong with this?
Blow up some of your cells if you have too much water being forced through them, or shriveling them up and dehydrating them if there's not enough water being drawn back out.
Yep, absolutely.
Which we were just talking about earlier.
Yep, absolutely. So 2 conditions that come off the top of my head will absolutely affect this. One,
Cancer.
What's that?
Cancer.
Yeah, cancer kind of affects everything. But yes, cancer.
No, I was just thinking the word oncotic,
Yep. Oncology.
Oncologist, I do
Yep.
know.
One is congestive heart failure. So our heart isn't pumping effectively, and as a result, fluid backs up. Fluid's got to back up somewhere. It backs up in our legs, in our arms, and in our lungs. So if anybody has a relative or somebody that you know that's got increased swelling in their legs, there you go. Increased hydrostatic pressure. Okay? When somebody has CHF and they have flash pulmonary edema, that's when the fluid backs up so much from heart failure into their lung space, and now they're not exchanging gases in their lungs to effectively oxygenate and pull carbon dioxide from their bloodstream. Another example of this is anaphylaxis. How does anaphylaxis work with this? That's an important one because that's one you're going to go to a lot.
Cuts down on the amount of air coming in and out.
It does. Yep.
Does it also
edema.
constrict your vessels? No.
The opposite.
Oh, that's right.
Anaphylaxis dilates your blood vessels.
Edema.
Edema.
Swelling.
Where does edema come from?
The fluid, typically attacking that area, causing the swelling, whether it be around the throat,
Yep.
tongue.
So when histamine
Lips.
is released, histamine is part of our inflammatory response. Histamine causes our cells to basically lose water more easily. So the permeability of our cell wall and our capillary bed increases, allowing that shift of fluid out of the cells and out of our tissues. It also causes airway swelling, so our bronchioles constrict. Doesn't allow good gas exchange, good air exchange in and out of our lungs. So we have a buildup of fluid. We have poor ventilation in and out of our lungs, and one other major thing that you said.
Constriction?
Dilation.
Dilation. I said constriction, so I was a little confused when you're like, the thing you said.
Close. So if our vessels dilate, all right, think of a fire engine. I always come back to this analogy.
Pump's gonna start firing.
So the pump is working. The pump's trying to pump blood, but it doesn't have the pressure.
So it slows down.
If we don't have the pressure to pump that blood effectively through our body, our vessels dilate, and now our vessels increase volume, but our fluid hasn't increased in volume in our vessels. That fluid's going to leak out into our tissues. Does that make sense? So understanding the difference between hydrostatic and oncotic pressures. Without enough blood, oxygen and carbon dioxide cannot be properly moved around. You may have a bleeding disorder from trauma, development of a GI bleed, any type of bleeding disorder, not production of not enough blood. Dehydration. We need to be hydrated to maintain the volume in our blood vessels to effectively pump blood around our body. If we're dehydrated, we don't have enough volume. Anemia. What is anemia?
Decrease in your amount of red blood cells.
Decreased red blood cells. So there's actually two forms of anemia. There's, what's that?
Sickle cell and regular.
So sickle cell anemia, that's a good one. What is sickle cell anemia?
Your red blood cells aren't shaped correctly, so it's hard for them to carry oxygen.
Yep. And as a result as well, you actually don't produce as many red blood cells. Another one is iron deficient anemia. So not enough iron in your bloodstream. Iron's the key component of hemoglobin that carries oxygen. You don't have iron, your hemoglobin's not carrying oxygen. And then just regular anemia is the lack of blood in your bloodstream.
That's why they test your iron level when you go to donate blood.
Yep. Exactly.
Yeah. I'm never high enough to donate.
It's alright. My girlfriend's the same way. She can't donate because her iron levels are always too low. Some people have to go on an iron supplement.
His are always too high.
Yeah.
Well, there you go.
I'm borderline too high.
Really?
Yeah, 20.5 is the highest, and I'm always like 19.5 to 20.
Yeah.
I'm way high.
Need to eat less spinach.
That's easy.
Right. Quit that.
It's the spinach that's doing it.
So another issue that can be encountered is liver failure. What does the liver do for our blood?
Cleans it.
Cleans our blood, gets rid of all the chemicals in our bloodstream, and it also stimulates the production of red blood cells. So red blood cells are produced in our bone marrow, and our liver takes that information in to say, hey, we need more red blood cells, or we can slow down, we don't need to produce as much. So if we have liver failure, we're either not producing enough red blood cells, or our blood is contaminated with toxins. It's not filtering out appropriately. What effect does this play on cellular metabolism? We have a blood disorder.
Well, it's not going to carry oxygen properly. It's not going to carry other nutrients properly.
So what form of metabolism is our body going to switch to?
Anaerobic.
Anaerobic metabolism. Because the key component of this whole thing is oxygen.
No oxygen, no lack of.
You said just switch to anaerobic. Perfect. Any questions with that? All right. Our blood vessels. You guys, we already covered this in anatomy, the understanding of our blood vessels. Arteries do what?
Go away from the heart.
And do they carry oxygenated or deoxygenated blood?
Deoxygenated.
Generally.
Both. Trick question.
Because of two, the pulmonary.
The pulmonary artery is the only artery in the human body that carries deoxygenated blood. Okay? So if you get that question on NREMT, I expect you to get it right, because they do love to trick you on that. They're going to ask you what defines an artery. An artery is a vessel that carries blood away from the heart. Point blank. That's it. So that's what an artery does. A vein carries blood back to the heart. Capillaries are the small vessels that kind of adjunct our arteries and our veins together. That's where cellular respiration occurs. They're very small, so nutrients, electrolytes, oxygen, and carbon dioxide can cross the capillary membrane going into and out of our cells. So capillaries carry both oxygenated and deoxygenated blood depending on what portion of the spectrum they're on. So blood vessels take oxygenated blood from the lungs through the heart and to the capillaries. Capillaries then offload the oxygen and nutrients and then take on the byproducts, which is carbon dioxide and waste products from the cells. They then carry it to the veins. The veins carry the deoxygenated blood back to our heart and to our lungs for offloading. So in blood vessels, we need adequate pressure to make the cycle work. We already talked about this. If you have no blood pressure means you're not perfusing. You need pressure in order to circulate blood throughout your body. All right. What's that magic number we look for blood pressure?
120 over 80.
120 over 80, depending what textbook you read, it may be 120 over 60. Normal, 120 over 80. This number is your systolic. This number is your
Diastolic.
good. What is this measuring?
The amount of pressure it takes to stop the flow of blood. Pushing pressure away.
And you
Good,
can start
good.
to hear it.
When you can start to hear it, yep. So if you're taking a blood pressure, that's the first thing you hear, is systolic. What are we actually hearing?
Thump.
You're hearing a thump?
How hard your
You're
heart is
hearing
pumping.
the upper.
What's that?
How hard your heart is pumping.
Pretty much, yeah. So
the
this
left
is
ventricle.
left ventricular contraction. So when our left ventricle contracts, that's what we're hearing. That gives us the pressure in our blood vessels, our arteries. Okay. Obviously, the pressure in our veins is going to be less than the pressure in our arteries. Arteries need that pressure in order to carry and efficiently pump blood through our body. So if we're hearing left ventricular contraction during this point, what are we hearing here?
Just the
Right
baseline.
ventricular.
Left ventricular relaxation. So at this point, our left ventricle is pumped. That's the pressure we're hearing. At this point, our left ventricle is relaxed. We're not hearing it contract. That's the pressure we're finding. There is a pressure called a mean arterial pressure, or MAP. It's the big golden standard pressure that we look for. And it's basically a mean sum of our systolic and diastolic blood pressure. There is one number that we need in order to adequately perfuse the vital organs in our body. Anybody know what that number is?
60.
Close.
40.
Map of 65, stay alive. Okay? So it takes a mean arterial pressure of 65 to adequately perfuse our brain and our heart. Anything less than that, we are not adequately perfusing our tissues. So if we're not perfusing them, our body switches to what kind of metabolism? Anaerobic metabolism. Make sense?
Yep.
So, pressure is controlled by changing diameter of our blood vessels. So around our blood vessels, we have smooth muscle, just like our bronchioles. That smooth muscle both relaxes and contracts to increase or decrease our blood pressure. We have stretch receptors that are within our arteries, mainly our carotid artery, our aortic artery, that monitors this pressure. Pressure can be increased or decreased depending on the situation. Okay? So if we're looking at a flight or fight response, what is that response called? Sympathetic response. Good. So our sympathetic nervous system kicks in. That results in our increased heart rate and increased blood pressure. If we need to rest and digest, what is that response? Parasympathetic. Exactly. So our blood pressure will decrease, our heart rate will decrease. Is there anything? Yep. Okay. Okay. So blood vessel dysfunction. So if we have loss of tone, our vessels lose the ability to constrict or dilate. That results in our blood pressure to drop. Causes of loss of tone include trauma, infection, and allergic reactions. So an allergic reaction, our blood vessels will dilate. It decreases the perfusion and circulation of blood through our bloodstream. Same thing with trauma. If we're losing oil out of the tank, dehydration, our blood vessels then can't use pressure to circulate blood throughout our body. A good visual of this is right here. So a normal blood vessel carries an adequate blood volume, adequate pressure to move blood throughout our body. A dilated blood vessel will result in reduced blood volume, reduced blood pressure, and trying to pump blood through that is impossible. It's hard. Okay. So, another form of dysfunction is excessive permeability. So capillaries will leak fluid out of their cell walls. That can be caused by severe infections like sepsis, high altitude sickness, and certain diseases. So those diseases include, well, they covered sepsis, which is pretty much all diseases to a degree. Allergic reactions as well will result in increased capillary permeability.
So I had altitude sickness this week. Really
That's
bad.
what we heard.
Oh, thanks.
As you said, she has good airway.
Would
Yeah.
DCS cause that too?
DCS?
Decompression and stuff, like
Oh, decompression sickness? Yeah,
bends?
the bends?
Yeah.
Yep. So what is the bends?
When a diver doesn't decompress coming out.
What's happening? They don't decompress coming up. What does that mean?
They have too much,
Acid
Too much nitrogen.
yeah.
Love it. Too much nitrogen. So what a diver is actually breathing in their tanks when they dive
Compressed air.
is compressed air, but it's a high concentration of nitrogen. Okay? Nitrogen is less buoyant, less heavy than oxygen. And so if we don't take the time to expel that nitrogen as we come up, that nitrogen builds in our joints, it builds in our muscles, and it builds in our vessels. Nitrogen will then displace oxygen, and it's basically looking for a way out.
In other words, they explode from the inside out.
No, they just get real loopy.
Yeah, to a point, if it's too severe, it can be detrimental. It can kill you.
Yeah, usually they just get stupid loopy for about 5 minutes, and then
Yeah.
it's
They usually initially present with like severe joint pain. So any movement of the joint, unless it's completely relaxed and extended, they'll have severe joint pain, and then they'll have symptoms consistent with like a fever, some kind of urticaria or hives, and then shortness of breath. So yeah, that's the bends. All right, so this is just an image of leaky capillaries. So our capillary permeability, the cells that make up our capillaries, basically allow fluids out of the cell more easily in the presence of anaphylaxis. That's exactly what's going on. Fluids are leaving our capillary beds into our interstitial spaces, and that fluid builds up somewhere. It'll accumulate in the lungs. Those hives and that swelling that you see, that's exactly what you're seeing.
So is that ultimately what's behind altitude sickness, is basically leaking fluid that builds up in the lungs?
Yep.
Okay.
That, and with altitude sickness, you have a lesser concentration of oxygen in the air.
Mm-hmm.
So your body ends up working harder because it's not receiving as much oxygen as it's used to. So people who try to summit Mount Everest without oxygen, Hillary was the first one to do it. He actually had to train for that because the oxygen concentration up in the altitude is so low.
It's like 12% up there or something.
Mhm.
It's crazy.
Yep. So, yeah, it's kind of a culmination of those things: leaky capillaries and less
I
concentration.
gotta tell you, when I was
oxygen.
sick with altitude sickness last week, it was literally like, it was the worst sickness that I've had in a long, long time.
Oh yeah.
Like vomiting, the whole 9 yards. And
Yeah.
within 5 to 10 minutes of having oxygen, I was back to baseline.
Yeah.
Yep.
It
You
was
were really
perfect.
quick to snap back, but.
Just had to get oxygen on board.
Oh yeah.
Well,
yeah.
when we went hiking, Rach and Bill
They
got
have low shoe
oxygen
bars,
because
some high altitude
we were up in horse
trekking
tooth,
range.
and that was almost 9,000
So when you
feet.
stop and after skiing, you can go there and get up to.
Oh yeah.
Yeah.
That's what
So
you gotta
we
do.
each
You gotta
were
train
once
for it.
Takes a
Yeah.
while. Yeah. Acclimate 3 to 5 days.
Yep. Oh yeah.
Well, and I mean, I probably have sleep apnea too. So like when
Yeah,
I
that
woke
doesn't
up with it the next morning, I think it was exacerbated by that.
Oh
It
definitely.
was nasty.
You're not breathing on top of the fact that you're not taking in enough oxygen.
Yeah.
Not a good combo.
Not good.
All right, hypertension. So hypertension is what?
High blood pressure.
High blood pressure. So our body relies on our systemic vascular resistance to pump blood throughout our body. Systemic vascular resistance is the pressure inside our blood vessels, our blood pressure. Various conditions can lead to abnormal constriction of the vessels, leading to an unhealthy high pressure level. Anybody think of one condition that causes high blood pressure?
I can think of a lot.
Go for it.
Occupational.
Yep.
Is
Stress.
Usually a big one.
High sodium.
High sodium. Yep.
Sort
Lack of sleep.
genetic conditions.
Yep. Genetic disorders.
Weight.
Weight. Definitely.
Smoking.
Oh yeah. Smoking, nicotine, caffeine, those all increase our blood pressure. How about heart failure? So heart failure is usually a result of hypertension, but it also exacerbates it, right? Because our heart isn't pumping as effectively as it should be. So it's relying on blood pressure to effectively push blood throughout our body. It's a major risk factor in strokes and heart disease. That's one of the leading risk factors for strokes, other than atrial fibrillation. So anybody with high blood pressure, one of the things we're really looking at is their risk of developing a heart attack, risk of developing a stroke or heart failure, any one of those things. It's a leading cause.
Unless it's untreated high blood pressure.
Yeah. So we can have something that's called hypertensive crisis, which actually can mimic a stroke. So somebody with hypertensive crisis, basically their blood pressure is so high that they're not effectively pumping blood to their major tissues, one being the brain. So our brain is then lacking perfusion, it's lacking oxygen, and it can mimic the signs of a stroke because it's not receiving the blood supply that it needs due to too high a blood pressure. So that's called a hypertensive crisis. So with our blood vessels, we can have loss of regulation. So chemical messengers tell blood vessels when to dilate and when to constrict. If signals are blocked, problems can arise. Lack of sympathetic response can cause shock. So the main one that comes to mind for this is opioids. Addison's disease as well can cause that. Any questions with that? The heart. What can go wrong with the heart? Everything. You have one heart. That's all you're born with.
Not always.
Well, that's true. There are some medical anomalies. You can be born with two hearts, or you can get a heart transplant if you qualify for one.
I know people that are heartless. Sorry.
I'll leave that one to you too.
I didn't even have to name it in.
No.
So the heart. The heart pumps with average stroke volume output of about 70 milliliters of blood per contraction, and that's our left ventricle. So during every left ventricular pump, it pumps out 70 milliliters of blood. All right, that's called our stroke volume. So the amount of blood that's pumped from our left ventricle out to our bloodstream is called our stroke volume. You need to know that, remember that definition.
In one contraction, though, right?
In one contraction. Yep. Along with stroke volume, we also have our heart rate. So how fast our heart is pumping. If you take the two, I'm going to jump ahead for a minute. If you take the two and you multiply them, you get what's called your cardiac output. So this is the heart's way of minute volume. So minute volume For our lungs is the amount of air we're taking in and how fast we're breathing. Now we have cardiac output, which is how fast our heart's pumping and how much volume of blood is being pumped from one contraction. Correlate the two. Okay. So stroke volume is based on 3 factors. Number 1 is preload, the amount of blood returning to our heart. So an indication for this is I give somebody nitroglycerin. Anybody's here on nitro? Nitro dilates our blood vessels. If it dilates our blood vessels, it reduces our blood pressure and our vascular resistance. If I give somebody nitro with no blood pressure, I'm reducing their preload. So if I'm taking away their preload, I'm reducing the effectiveness of each heartbeat. Another factor is contractility, so how hard the heart is squeezing. And then afterload, which is the pressure that our heart has to pump against to force blood into the system. Is afterload a good thing? Do we need afterload? Yes, we do need afterload. You need afterload.
That was going to be a trick question. I was
It
very
was.
confused as to...
You need all 3 of these things. If you're missing one of these things, you're in what's called heart failure. Your heart's not pumping effectively. So you need preload. You need some form of blood returning to the heart so it can pump it around. You need your heart to force contraction, so to contract effectively. And your heart needs to push against something. If it's pushing against nothing, then it's not going to effectively push that blood. So like I said, stroke volume times beats per minute is your cardiac output. Anything affecting one of these 2 things will affect your cardiac output. So slowing heart rate or decreasing stroke volume reduces your cardiac output. On the opposite end of the spectrum, if our heart's pumping too fast, that reduces our cardiac output. How?
There's not enough time for blood to get into the heart for it to be adequately pumped out and oxygenated.
So is that affecting preload, contractility, or afterload?
All of the above, right?
More one thing than the other. Preload. So the amount of blood returning to our heart, the amount of blood going to our ventricles to be pumped away from our heart. The heart needs time to allow blood to go back into our ventricles. If it's pumping so fast that it's not allowing the ventricles to refill, then it's basically not pumping anything. So it's working harder than it needs to, and it's ineffective. Examples of this would be somebody in ventricular fibrillation, ventricular tachycardia, supraventricular tachycardia. So if anybody's ever had a heart rate above 160, it's not good.
I thought it was supposed to be 200 minus your age.
Yeah, to an extent. So if you're doing like a hardcore excessive workout, yeah, you're looking for your target heart rate because that's when you're burning most of your energy, most of your calories. But you don't want that when you're sitting still, not doing anything.
Okay.
That's not good. Right? Pediatrics. So infants and young children rely on their heart to compensate for poor perfusion. Lack of contracting muscles. They cannot regulate the force of contraction, and a fast heart rate indicates compensation. So they lack the ability for vascular tone, so increasing or decreasing their blood pressure, and they rely on their heart rate for perfusion of their tissues. So when we take a vitals on a pediatric patient, we're looking at one major thing, which is their heart rate, to tell us how sick they are. If their heart rate's through the roof for their age, that's telling us, all right, they're trying to compensate for something, and we need to figure out what. The other thing with that is their respiratory rate. The major cause of cardiac arrest in kids is respiratory failure. Kids rely on oxygen heavily, so if they go into respiratory failure, ultimately that leads into cardiac arrest. So whenever we go to a pediatric patient, one of the major things we treat first is their respiratory system. Supply with oxygen, bag them if needed. Those are kind of the 2 major things. So heart dysfunction. We can have mechanical problems and we can have electrical problems. So mechanical being the physical pump. This includes physical trauma, so cardiac tamponade, Another would be, oh God, I'm gonna botch it. An infection of the heart, endocarditis. Anything that can affect the squeezing forces or result in cell death, so a heart attack. If somebody is not oxygenating or perfusing a portion of their heart, they're having basically a heart attack. That's what a heart attack is. Cell death to the heart from a blood clot or narrowing of blood vessels. And that's where they go in and they get a stent to open that blood vessel back up, remove the clot, and start perfusing those heart tissues again. So a heart attack is considered a mechanical problem. Electrical problems include damage to the heart's electrical system, and this can be caused by unorganized rhythms and rate problems. So remember that picture we drew where you can see the electrical system of the heart? So any damage to any of those areas can result in electrical problems, and that can result in abnormal cardiac function. So an example of this, common in the population, atrial fibrillation. You guys have heard of it? It's quite common in the older population, and it's basically, that's part of our electrical system. So in atrial fibrillation, normally our atria pump effectively, one beat at a time, send the blood from our atria down to our ventricles. During atrial fibrillation, our atrial cells are all firing at once. So instead of doing this, our atria is doing this. That's not pumping blood effectively at all. All right? We can still live because our body relies on our ventricles to pump blood throughout our body into our lungs. Our atria's job is to just pump blood from the atria to the ventricles. Make sense? So putting it all together, the cardio and pulmonary system. The entire cardiopulmonary system must work together to maintain life. They must work in unison. They must be able to balance between ventilation and perfusion for the system to work properly. So that's called the ventilation perfusion match, VQ match. If we have a VQ ratio can be disrupted by any challenge to the cardiopulmonary system. That results in what's called a VQ mismatch. That's going a little more in depth than you guys need to go, but basically anything that affects our respiratory system or our cardiac system can result in a VQ mismatch. Primary example of this is pulmonary embolism. Pulmonary embolism results in a VQ mismatch. And what that means is we have an embolism in our pulmonary artery. So that blood that's clotted in the pulmonary artery isn't reaching our lungs. If it's not reaching our lungs, it's not able to pick up oxygen and offload carbon dioxide. So as a result, our oxygen saturation decreases, our respiratory rate increases, we develop chest pain, and our heart works harder to try and perfuse the rest of our body because it's not picking up oxygen. That results in a VQ mismatch. Does that make sense? Okay. Last unit, shock. I'm trying to get to my 9 o'clock. We're getting there. This is the last part. I'll kind of hurry through this one. All right, so we have shock. So for perfusion, it's a regular delivery of oxygen and nutrients to our cells and the removal of waste products. That is perfusion in a nutshell. Shock is hypoperfusion. So you really need to understand the definition of perfusion. Remember, it's the delivery of oxygen and nutrients to our cells and the removal of waste products. Hypoperfusion is inadequate perfusion. So basically, it's a breakdown in our system. It's the death of cells because they're not being perfused. Those cells aren't receiving oxygen and they're not able to offload their waste products. The cell dies due to hypoperfusion. Ultimately, what kills you is shock. Everybody. When we die, we go into shock. It doesn't matter how you die, your stages of death include shock. This is what we work to recognize in the field. If we identify that somebody's in shock, then we know they're knocking on death's door and we need to intervene immediately to fix it. This is the big thing we're looking for. There are 4 categories of shock. Technically 5. We'll talk about 4. So the 4 categories include hypovolemic, which is low blood volume. There are 2 subsets of hypovolemic. You have hypovolemic non-hemorrhagic and hypovolemic hemorrhagic shock. What does that mean?
Hemorrhagic means you're bleeding. And you're losing
Beautiful.
volume.
Yep. So hypovolemic hemorrhagic shock is from blood loss. So you're bleeding from somewhere, typically trauma, or an upper GI bleed, lower GI bleed. Those are the most common. Hypovolemic non-hemorrhagic is a form of dehydration. All right. We don't have enough volume in our vessels to adequately perfuse our tissues. So we can go into what's called hypovolemic shock. This is one of the big things we're looking for in dehydration. The next we have is distributive shock. Low blood vessel tone. Okay? So this is when our blood vessels dilate, the volume in our blood vessels remains depleted, and it's not effectively pumping blood through our vessels. What's an example of distributive shock?
That would be anaphylactic.
Beautiful. Anaphylaxis. Anaphylaxis is a form of distributive shock. When we get into the shock chapter, we're really going to hammer down on the difference between these. You will absolutely 100% be tested on these on your NR EMT exam. I can tell you with that with 100% certainty. They're going to give you a question. A patient presents with anaphylaxis. What form of shock are they in? You got to know it. Okay? So really, if there was anything for you to study, it is these.
Isn't that fifth shock like anaphylactic shock though? So
Anaphylaxis is a form of distributive shock. So you can go into anaphylactic shock, which is a form of distributive shock. Our next is cardiogenic shock. So cardiogenic shock is when the heart fails to pump, cardiac. So a heart attack is a form of cardiogenic shock. Pulmonary embolism results in cardiogenic shock. Congestive heart failure, cardiac tamponade, endocarditis, those are all form of cardiogenic shock. So anything that results in the heart to fail in its pumping action.
would getting stabbed in that area also be cardiogenic shock though?
Yeah, that'd be cardiogenic and hemorrhagic hypovolemic. You get stabbed in the heart, that's never a good thing. So, good question though. Obstructive shock. Blood cannot flow. Blood can't go anywhere.
Heart attack or
Stroke.
Heart attack is more towards cardiogenic. So, when I said pulmonary embolism, I misspoke. Pulmonary embolism is a perfect example of obstructive shock. Stroke. That's a good one. Yep.
So blood clots.
Blood clots in general.
Yeah.
Yep, are a form of obstructive shock. There is one more on here. They didn't include it. I'll just mention it to you. Neurogenic shock is the other one. Your book doesn't really talk about it. Basically, neurogenic shock is something that is seen with somebody with spinal cord injuries. So basically, with neurogenic shock, their body has lost all ability to maintain tone. So not only is that affecting them neurologically, it's also affecting their blood vessels, their respiratory drive, their cardiac output. That's all part of neurogenic shock. Your book doesn't really talk about it, so I'm not going to go in depth about it, but just so you guys know, there is a form of neurogenic shock.
It's like brainstem injury.
Yep.
Spinal cord injury.
Yep. Absolutely.
What about electrocution?
Electrocution?
That would be more like hypovolemic or.
Great question.
Cardiogenic, I would think. It's probably going to stop the heart.
Depends where you get shocked. Let's take electrical burns, or burns in general. What form of shock would burns be considered?
Well, that's a burn, though. That's not electrocution. Electrocution would result in death.
Depending where you're shocked.
I've
However,
electrocuted myself before, and I'm still here.
you're just lucky you didn't get shocked with 200 amps.
Distributed.
Cool, amps will kill you.
So,
Go ahead.
sorry, the question wasn't answered, but I have another one.
What's that?
If somebody witnesses something traumatic and you say they're going into shock, which one of these would that be?
So, how are we going to identify that somebody's in shock? What are we looking for?
Mental status change.
right there. Mental status changes. They go unresponsive. Increased heart rate, increased respiratory rate, or irregular respiratory patterns. Delayed capillary refill, skin color, excessive sweating. Those are all signs of shock. One big one on here is hypotension. So if they have a high heart rate, high respiratory rate, shitty blood pressure, they're in shock. All day, every day. Okay? Back to your point. Did you say distributive?
Yes.
So, yes.
Yeah.
It'd be a form of distributive. It would also be a form of hypovolemic. So, in burns, all right, let's take a thermal burn, for example. With a thermal burn, our capillary beds become permeable. So we lose excessive extracellular fluid. We leak fluid out of our burns, all right? And one of the big things we go under is distributed shock, and we also go under hypovolemic shock with burns. Now with electrocution, those are actually considered internal burns. So we're not really seeing burns on the outside. You'll see an entrance and an exit, but internally, that's actually a form of burn on our tissues inside, depending where you got burned. So
you treat by giving
fluids.
A lot of like repair work is electricity flow is in the path of least resistance. It's
Yep.
like water. If it's going through your veins or arteries, that's
Wherever it wants to go. Yep.
Where it actually develops grounding.
Yep. Exactly.
You could also have cardiogenic.
Yeah.
Because it could cause cardiac arrhythmias that might not make the heart function properly. So
Yep.
you could have a form of cardiogenic.
Yep, that's true. So when we're shocking somebody, we're sending electricity through their heart from a positive center to a ground. And that's just, we focus it right on their heart to try and reset their electrical system in their heart. So back to shock. There's 3 forms of shock. You have compensated, decompensated, and irreversible. Okay? So early signs of compensated shock include mental status changes, increased heart rate, increased respiratory rate, delayed capillary refill. How do we check that?
Fingernails?
Squeeze their fingernails. What's normal?
2 seconds or less.
2 to 3, give or take, depending on how old the population is.
Fingers outside too.
Yeah, temperature outside definitely plays a factor. If we start getting up into times above 4 seconds, I've had patients that are up to 8 seconds in delayed capillary refill time. So that's a good indication of what type of shock they're in. Pale, cool, clammy skin. This is our big one. You can look at somebody and say, wow, they look pale, diaphoretic as hell, and they're complaining of chest pain. You're in shock. You're in cardiogenic shock. That's our most common sign of a heart attack. Joe knows the STEMI look. We call it the STEMI look. We can literally look at somebody without doing an EKG and say, yeah, you're having a STEMI. Hands down. And it's the classic pale diaphoretic look. Excessively sweating, extremely pale skin, and that's all from lack of perfusion because their heart's not pumping effectively. Decompensated shock occurs when our compensatory mechanisms fail. It's characterized by decreased blood pressure and altered mental status. So we're seeing high heart rates, high respiratory rates, and now their blood pressure's gone. Now we're really working against the clock. If we find somebody in decompensated shock, first of all, you have to treat what's causing the shock. Try to identify and recognize whether it's respiratory in origin, cardiac in origin, neurological in origin. You have a question? We use this to differentiate what form of shock they're in, mainly by their blood pressure and their mental status. When they get into irreversible shock, this is when inadequately perfused organ systems begin to die, and this is when they go into MODS, multi-organ dysfunction syndrome, when all their organs start to fail. We can't fix that. When you go into irreversible shock, it's basically imminent. They're going to die. The mortality rate for irreversible shock is up above 80%. It's not something we're going to fix. And these are usually late signs. So if we see somebody with agonal respirations, heart rate of 20, unresponsive, mottled skin, those are all signs of irreversible shock, things that we can't fix.
if you're seeing that and you know that there's 80% or better chance they're about to die, are you still performing rescue measures?
Yep.
To that point.
Yep.
You're at MCI.
Yeah, and MCIs are a different game.
Yeah.
So anytime we go to a patient, even if we find them in irreversible shock, we're still going through the motions, doing CPR. So keep in mind, unwitnessed cardiac arrest, survivability in the field is less than 5%. We still do it. You know, any patient, if it was my girlfriend or relative or whatever, yeah, I want you to make the effort to try and save them, even if it's at 5%. We'll try, because you never know.
Well, I'm just gonna say, remember, it's upwards of 80%, so you still have that 20% of the population where your actions may
make the difference.
You may make the difference to get that patient to the help that they need to reverse it. Typically, that means advanced level.
You may end up prolonging the inevitable.
Yeah.
You know, depending how far along they've gone. If they've resulted in kidney failure, liver failure, you do your work to save them.
You give them the fighting chance.
Yep.
Well, even if you're prolonging it, you're giving the family the benefit to say goodbye, or
Yep. Absolutely. So we make the attempt. It's not very successful, but we try. The big thing we do is try to recognize if they're in compensated or decompensated shock, because that is where we can make a huge difference. If we don't reverse whatever's causing them to be in shock, or at least try and stabilize. So a perfect example, somebody's bleeding from their femur. You know, they've got a gunshot wound to the femoral artery. It takes 90 seconds for you to bleed out in your femoral artery. What can fix that? Tourniquet.
Maybe?
A hot knife.
No.
Cauterization. So yeah, just a tourniquet application can prevent them from going into irreversible shock. You know, at the medic level, if we shock them out of a cardiac arrhythmia like VTAC, anything like that can make the difference. Our job is to recognize right off the bat, are you in reversible shock, or compensated shock, or decompensated shock? That tells you how far along in the game you are. And then patho of other systems. That's all I had for tonight. Did you guys have any questions on this? There's a whole shock chapter that we're going to go into, but this is just a broad overview. Alright, that was 15 minutes over. No, 28.